together what is a great meeting, and also Dr. Cheng for showing me around the hospital yesterday, and also I was truly impressed at the fellows, the residents, the attendings, and etc. that were part of his team. It was an impressive group. And he was nice enough to take me over to the National University yesterday, where we were able to interact with some basic scientists and clinicians. And you just have a tremendous number of really high-quality scientists, clinicians, and that you can actually work together is very impressive. So what I'm going to be talking about today is cancer pain. So you can just sit back. And so my objective is to suggest to you, at the end of this talk, what I'd like you to basically think about is just when you see your cancer patient, you'll have an idea of where does the pain come from, what are some of the mechanisms which generate it, and get an idea that in many cases, these are the mechanisms which are driving it, but also, at the end of the talk especially, you'll see how their peripheral nervous system frequently reorganizes itself in response to the cancer. So I think we all agree that, as a cancer grows, and I'm going to be talking about bone cancer, you'll see that the bone changes and the cancer evolves. But what I'm going to try to show you is that what's also happening is the sensory and sympathetic nerve fibers which innervate the bone and which innervate the cancer are also changing with the disease. So when you're attempting to manage the patient, the cancer patient's pain, you should try to think in terms of, it's not the nervous system that you and I have, it's a changed nervous system, and really the disease changes the nerve fibers, and really in quite remarkable ways. So when you're trying to control the pain, and it really fits very well with the previous talk, you'll see that there's a very significant neuropathic component that we just didn't appreciate 5 years ago. If somebody would have told me that these nerve changes were taking place, I would have said, I don't believe you. But when you actually have animal models, and I think that's the other major point of the talk, is that really all of the research I'm going to be talking about is really because of clinicians. Some time ago I was talking to the people out at Sloan Kettering, Kathy Foley, Rich Payne, Russ Portnoy, who were cancer pain specialists. And one of the things they said is, we treat the cancer pain, but we really have no idea of what are the mechanisms which really drive it. We really didn't have any preclinical models nearly a decade ago. And so the lab set out to try to develop preclinical models and then use the preclinical model. And I should say that throughout the entire development, we were always talking to the clinicians, asking them the question, is this what the cancer looks like in your patients? Is this what the bone looks like in your patients? And I think without that interaction, we couldn't have had the success that we've had. So I'm going to be talking to you about, I don't think you have to take any notes, but at the end of it, I hope you actually have an idea when a patient of yours presents with bone cancer pain or with cancer pain, you'll actually have an idea of what are the general mechanisms that's driving it, how have things changed, and how do we actually basically try to treat this particular disease. So the first thing is that the global statistics of cancer are impressive. You would have thought that given the advances we've made in cancer therapy, well, primarily diagnosis, but also treatment, that this would be going down. But you can actually see that the number of patients that we had in 2008, 13 million, is going to go up to 21 million. I mean, the truth of the matter is we've become much better at diagnosing and preventing cancer as opposed to actually treating it once it's actually there and metastatic. So when you actually look at the number of deaths, it's going to go up and not down unless there's some major changes which occur, I shouldn't say changes, successes which occur in our understanding of cancer. And so the causes for this increase is really the growth and aging of the population, and this is really the major one which is driving it. If you actually look at the life expectancy in both the developing world and the mid-developing world, it's remarkable how quickly the age, the survival is going up in those particular populations. Those individuals are going to get cancer, they're going to have cancer pain, and they're going to need treatment. So the number of cancer patients that we'll have in future years will be more and not less. Okay, one of the major problems we had initially was there's obviously a lot of cancers. And when you're going to develop a preclinical model, and you're going to, after talking to Kathy Foley and the folks out at Sloan Kettering, the question was, well, which cancer model should you develop? Should you try to develop a mouse model of pancreatic cancer? Should you try to develop a mouse model of bone cancer? And I think it was really Rich Payne was the one that would seal the deal. So what he pointed out was that if you actually looked at 255 cancer patients with metastatic lung, prostate, breast, I mean basically common cancers, and if they were reporting a pain intensity of greater than 4, 0 is no pain, 10 is the worst pain they've had, and you ask the question, well, where do they actually most attribute the pain? Obviously, they can be more than 100% because you can have it in different areas. What Rich pointed out was 84% of these people basically had bone pain. So at that point, I think that we thought, okay, if these are common cancers, this is a likely place that they actually metastasize to, we should try to develop a model of bone cancer pain. And that's really what led us there. So if you look at the progression of bone cancer pain, and again, it was very useful to spend time with the clinicians and actually be in the room where they're interviewing the patients. This is what you saw. It was frequently present as an intermittent pain at first. Frequently, the patient actually thinks they have arthritis. Then it ultimately becomes a constant pain, and this is the pain which is obviously, as clinicians, you know, is the most difficult one to control. It's this breakthrough pain, where it's an extreme pain associated with even normal activities, turning in bed, blood movement, and coughing. So we had really the spectrum of what we wanted to look at. We said, okay, the pain gets worse with time, but again, it was with the clinicians that we were able to see, okay, this is what happens in humans, and seeing the patients, can we actually develop a model that looks something like that? Well, the first question I think many people had, and just this prior speaker said, you know, if you can't tell it to your grandmother, you probably don't know it. Of course, the question is, why would somebody who has breast cancer, prostate cancer, lung cancer, why is it ending up in their bones in the first place? You would think that the pain would be locally. And it's really, it's something that, in studying bones for the last 10 years, it's a remarkable organ. But for example, if you had a primary malignant neoplasm, for example, let's hope it doesn't happen, but let's say I had prostate cancer, you would have then the neoplasm here, you would have the neovascularization or formation of new blood vessels, you have invasion of the tumor, now you have the tumor cells floating around. This is before I even know I have the cancer. And then ultimately they arrest in the capillary beds. And if you look in the bone, there's a very unique capillary bed. They're very leaky vessels. Red blood cells and white blood cells are formed there. They have to exit there. So things come in and go out of the bone very easily. And we think that there's something unique about these endothelial cells which allow the tumor to basically escape and then frequently become quiescent, i.e. they stop dividing. And then 5 months to 10 years later, the patients receive the chemotherapy treatment. They basically receive the cancer treatment. They show up at the physician, and we had a gentleman in the pharmacology lab, in the pharmacology department in Arizona, Hank Yamamura, who some of you may know. He basically showed up, never smoked, showed up at the physician's office and said, I've got back pain. They originally thought it was arthritis. It turned out he actually had lung cancer, which had metastasized to his bone. So that was the first, if you will, symptom that he had cancer pain. So these things metastasize to bone, and prostate cancer, we'll see in a moment, breast cancer, lung cancer, are all avid metastasizers to bone. And so this is simply a picture of cancer patients with breast cancer, lung cancer, or prostate cancer, and you can see where the tumors metastasize to. And of course, the problem with patients with metastatic breast cancer, prostate cancer, lung cancer, is it doesn't metastasize to one bone. I mean, look at the prostate cancer patient. I mean, it's up and down the vertebrae here, it's in the pelvis and the ribs. I mean, so it's difficult to say, well, I'm going to simply treat one spot when the cancer is so widely disseminated. So given this, we then said, okay, what model can we develop to actually begin to look at this? And so this is what it really looks like. So I showed you a picture of where the cancers are here, but if now I show you an x-ray of the bone to say, what does the bone look like, this is a typical picture. You see a normal, here would be the normal femur, this would be the knee joint here. I mean, people have basically injected tumor cells in the bone before, but they really couldn't keep them there. And what they were able to do is inject, so this would be a mouse, you take a needle, you inject the tumor cells, and because it's a mouse, you can inject whatever tumor cell you want. You can inject human lung, human breast, human prostate, so you can inject what you want. And the key was, and it was actually somebody from Saipan, who was the oral surgeon, she was really good at basically putting dental amalgam in, and she could plug it. So we could confine the tumor to one and only one bone, and we always transfect the tumor cells with a reporting protein, a green fluorescent reporting protein, because at that point we can actually, these are the tumor cells growing at day 6, day 10 in the marrow space, and then at day 14. But the beauty of the model really is that in the same animal, you can measure pain, tumor growth, bone remodeling, and tumor metastasis. Because when you really think about who do you have to convince when you're going to give an analgesic therapy, the first person you're going to have to convince is the oncologist. And if you don't know what your potential analgesic does to the tumor, they're going to say, well, maybe the analgesic that you give is going to cause the tumor to grow more. And if it is, they're not going to give that analgesic. So I think it's a useful model because you can not only look at the pain, but if you have a therapy which reduces the tumor growth or the metastasis or bone destruction, the same model and the same animal, you can measure all 4 things at once. And obviously the other thing you need then is pain behaviors, and what you see in these animals is just what you see in humans. This would be days after tumor injection, and the pain, the spontaneous guarding, and the flinching goes up. And it's just in the paw that basically has the tumor. So now we have the tumor growing, we can measure how much tumor there is, we basically have spontaneous and guarding. So we have a model that we can actually begin to look at novel therapies. And then what you see is, and this is the same thing you would see in a patient with, for example, a sarcoma or a breast. If the tumor's in here growing, it basically begins to cause bone destruction and bone remodeling in the places which have the greatest stress in the bone. So you can see here, this is the femur, this would be the proximal head, this is the distal head. Notice that the mid-shaft here, you see very little remodeling. We think that there are more growth factors down here in the place where the bone has more stress. And it looks very similar to what you would see in the human. Okay, so for the rest of the talk, I'm going to suggest that there are really 3 things you have to think about when you see the patient with bone cancer. We think that there are 3 major mechanisms which are driving the pain, and you need to think about targeting them independently when you're giving therapies. There's going to be a tumorigenic component, an inflammatory immune component, and lastly, this neuropathic component, which I think was very unexpected. We really thought that it was going to be these 2 which are going to be the primary ones, and in the last several years, we really think that this is going to be one of the major ones which is driving cancer pain, probably not only in bone, but also other organs. But just for the next few minutes, we'll talk about the tumorigenic. And this was where we teamed up with an orthopedic surgeon, and we also teamed up with Amgen, which is a biotech company located in California. So if this is the bone, inside of bone here, and you have your tumor cells growing here, we also know that tumor cells are almost always accompanied by inflammatory cells and immune cells. And then the thing that really resorbs the bone, remember when I showed you that sarcoma bone and it looked moth-eaten? It's not the tumor cell itself which is destroying the bone. It hijacks the cells that you and I have in our body, which are normally present there, and you have osteoclasts. So the easy way to think about it is the clast cuts bone and the blast builds bone. So the osteoclast is the thing that really begins to become, there's many more of them, and they're much larger once the tumor invades. So if you were to look in, for example, this would be the normal bone, this would be a sensory fiber which innervates the bone, which then goes to the spinal cord. This hopefully would be my bone inside, this would be the cortical wall, this is the marrow space. You'd find one little osteoclast sitting here or there. Once the tumor comes in, you see not only more osteoclasts, they get bigger, they're really effective at breaking down bone. That's why patients with bone cancer frequently actually have fracture of the bone, because they have too many osteoclasts, which the tumor's driving, and ultimately results in bone breakdown and fracture. So the question we really asked then was, if we blocked the activity of the osteoclast, could we actually relieve some of the pain? And this idea of fracture in a bone cancer patient is a huge issue, because once you actually have fracture of the bone when you have bone cancer, there's very little likelihood that it's going to be able to repair itself. So what we teamed up at that point was with Amgen here and Roche here, and asked the question, if you gave either of these therapies, could you relieve the pain? And where we think the pain is coming from with the osteoclast is that the way the osteoclast resorbs bone or breaks bone down, it basically forms this very acidic environment. It's called the resorption bay. And once you actually have, so the pH here is really between 2 and 3, very low. And on the sensory nerve fibers, we know that they have channels which can sense acidosis. I mean, it's a little aside, but if you have children and they have growing pains, that's really where it's coming from. In the bones, if their bones are remodeling so quickly, the osteoclast in the bones of a growing kid will actually stimulate the sensory fiber, and some of them actually have growing pains in their bone. Think about that 10 or 100 times greater than that in a patient with bone cancer, and that's the pain that really these osteoclasts are driving. So we used denosumab and the bisphosphonates. They target it in a different way, but basically if you give these therapies, you can basically get rid of the osteoclasts in these patients. So the idea was that here you have the tumor cells, here you have the nerve fibers, here you have the bone, and that osteoclast is beavering away there, and the question was, is this actually contributing to bone cancer pain? And they had a new therapy at the time called denosumab, and what this actually does is it interferes with the osteoblast's ability to talk to the osteoclast, and the tumor to talk to the osteoclast. If you give this therapy within 2 days, it's difficult to find an active osteoclast in the body. It's remarkably effective. The question was, is this actually going to be effective for treating bone cancer pain? So this is what it looks like, the bone destruction looks like in the mouse with the sarcoma growing by itself. This is basically when you have the tumor growing and you have either a bisphosphonate or denosumab aboard. You basically stop bone destruction in its track because you don't have the osteoclast to resorb bone. And if you ask the question, do you reduce the pain? If you look at spontaneous flinching, or if you look at spontaneous guarding, you see them both reduced. So this would be the ongoing pain, and this would be the movement evoked pain. You get about a reduction in the pain by about 50%. This ultimately appeared in Nature Medicine. You can see how long ago it was, 2000. But eventually this actually made it to both clinical trials, and both of them are now approved to treat bone cancer pain in patients with either metastatic breast, prostate, lung, etc. And here's just an example of a study that a colleague did comparing a bisphosphonate and denosumab. But the bottom line is you can prevent things like fat fracture, the need for radiation therapy, spinal cord compression, and pain in these patients. And it gives them basically another 2 to 3 of disease-free survival before they'll have the fracture. So almost every patient which has metastatic breast cancer, prostate cancer, lung cancer, which has metastasized the bone, is on either a bisphosphonate or denosumab if they're under current therapy. So it was a case where we basically took a clinical finding, was able to move it to a clinical trial. It was approved, and now this is the standard of care of treating patients with metastatic cancers which have metastasized to the bone. Okay, the second thing we think drives basically the bone cancer pain is this idea of inflammatory and immune cells. And so we have the same picture here. So if we have the tumor cells here, we have inflammatory cells, we have the osteoclast. The question is, do the sensory nerve fibers here which innervate the bone, can they sense the things which are being released here? And if we block some of them, can we actually reduce the pain? And the thing we teamed up here was with a small biotech company called Renat, which had an antibody against nerve growth factor. So the question we're really asking is, can the blockade of factors released from inflammatory immune cells attenuate bone cancer pain? The reasons we thought it was going to be more effective at reducing skeletal pain as opposed to skin pain is the great majority of nerve fibers which innervate the bone. It's the nerve growth factor which is released from the immune cells or the tumor cells Once it's released, it then binds to its receptor tract A. This would be the distal tip of a sensory nerve fiber. And it's a master regulator of all the other things that basically signal noxious stimuli in the bone. So the question is, okay, is this therapy going to work? Again, fortunately, I was able to team up somebody who was very good, Dave Shelton, who worked at Renat, who I knew as a grad student. And this is what it looks like. And I will simply tell you this. There's now a monoclonal antibody that is being used in humans. Basically very similar to this, has a longer half-life. But this type of therapy then has now resulted in a clinical trial. So this particular antibody blocks binding of nerve growth factor to TRAC A and P75. It's specific for NGO of other neurotropins. So it's a monoclonal antibody. You simply inject it intramuscularly into the patient or the mouse. It has a half-life of 5 to 6 days, and it doesn't cross the blood-brain barrier. And what you see is that what you get is about a 50% reduction in the pain in this particular animal model of bone cancer. So this would be the pain here. We're looking at the number of flinches again here. And this would be the animal basically without. This has the prostate alone. And this would be the prostate plus anti-NGF. And what's impressive is that even 70 days out, you basically still remain the pain. You basically still retain the pain relief. So this was impressive, but the question is obviously, well, that's great. You showed that in a mouse. I would like to actually see some results in the human. And so tanezumab is now the name for the monoclonal antibody which is used in humans. So this is tanezumab for the treatment of knee pain. They thought, well, if he's able to relieve the skeletal pain in bone cancer, and they currently have a clinical trial running for that, maybe it can also relieve the pain in osteoarthritis, fracture, and other more common skeletal pain. So using the data we generated, they went out and tried a clinical trial, and this is the results of that. So this was the results. This is looking at patients with osteoarthritis. These are humans. We're not talking about mice anymore. They basically, they have to have a pain score of greater than 4 to enroll. They had to be over 65. And this is dose 1, dose 2. And what you can see is that the average reduction in pain in these patients is between 40 and 50%, which is very similar to what we had in the prostate. There's now been 12,000 patients which have been treated with this for osteoarthritis. It's also been looked at low back pain. I will simply say that it works better in skeletal pain than it does other types of pain, probably because of that neurobiology idea that most of the nerve fibers which are innervating the bone are actually TRAC A positive. So I think it's another example of taking preclinical work, working with clinicians, working with a pharmaceutical company, and ultimately getting to a successful clinical trial where you can actually see significant pain relief. I mean, one of the things we now know, which we don't really know for skin or visceral pain, we've got a fairly good idea of what drives at least 50% of the skeletal pain in osteoarthritis, because this is anti-NGF, which is blocking 50% of the pain. Okay, the last thing I'm going to talk about here is really this idea of the neuropathic. And this was the really unexpected part of the studies. As I said before, we really thought this, and I think the people in the cancer field thought this is where most of the pain is coming from. So when we inject the tumor cells into bone, we know that there are small numbers of nerve fibers which normally innervate the marrow in mineralized bone. And certainly as the nerve fibers go through, they're going to injure and destroy the nerve fibers which are normally innervating the bone. So here you would have your basically normal bone marrow. This would be a blood vessel inside the femur. This is basically the nerve fibers in the little green here and the little red. Those would be your normal nerve fibers in your marrow. And this, you can see how the tumor has a different histology. Normal, basically these are red cells and white blood cells. Once the tumor comes through, it basically destroys all the sensory fibers in its path. You kind of expect that. I mean, once the tumor comes through, it first basically destroys the tissue, it has neovascularization, and then it becomes necrotic. This would probably give you a neuropathic pain, but there's not that many sensory fibers in bone, so you'd say, okay, maybe it's a minor neuropathic pain. It was really this clinician in Australia that basically pointed out that he said to me, there must be something different about breakthrough pain. There must be some active component driving it. This is a 62-year-old woman who had breast cancer, was living on her farm, And you can see that she has one breast cancer metastasis right here in her arm. And then ultimately, you can kind of see just a little bit, she has a fracture. And after this, before this, she had lived 4 years on the arm with metastatic breast cancer. The pain became so intense that she had to be transferred to the hospital, and she died 3 months later. But the point that Dr. Semple made was, there must be something active because her pain went off the charts. And because she had osteoporosis, he really couldn't stabilize the bone. So it's this idea here of this breakthrough pain that Dr. Semple argued this patient had. So he said, you know, this patient here, I can control her persistent pain, but I cannot control these flare-ups of pain that she began to have. And when he asked me, you know, what do I think is causing the pain? I said, I think it's just merely more acidosis, and I think it's more inflammatory cells. And he said, I don't think so. I think it's something really different that you haven't thought of. And, well, he was right. So, what I thought of on the way back, which was in Australia, it was a long plane ride, I thought about the similarities between breakthrough cancer pain and what you have in a painful neuroma if you have limb amputation, which is that the pain is movement and vibratory evoked discharges. It can be spontaneous, out of nowhere, if you have a neuroma. Ectopic discharges, it's frequently disabling, chronic, severe. It's refractory to medical treatment. Same is true with breakthrough pain. And this idea that the nerve fibers begin to express things they never did before. So I thought about it and I said, well, what if the inflammatory immune cells, or the tumor cells which come into when the tumor invades the bone, what if they express nerve growth factor? And I don't know if you remember this lady, but she's Rita Levi-Montalcini. She's the one who won the Nobel Prize for nerve growth factor. But the bottom line is what her work was, she would take out dorsal ganglia, sensory ganglia, she'd plop it in a culture, and then she would basically, this would be what it looks like, that little group of sensory neurons, if you don't give it anything. And this is what happens when you put nerve growth factor on it 18 hours later. I mean, it's truly impressive how quickly nerve growth factor can basically generate the sprouting of the sensory nerve fibers. So the question was, well, maybe this happens in cancer patients. Maybe as the tumor, the inflammatory immune cells, which always accompany the tumor, maybe they're going to express nerve growth factor. Maybe nerve fibers are sprouting in the cancer patients, and that's driving their neuropathic pain. So the idea would be that you have these cells releasing nerve growth factor, you get these new sprouts, and that this is going to be more or less like the amputation pain. You're going to have the ectopic sprouting and the ectopic discharges. And indeed, there was somebody in the lab who showed this, and I was, to be honest, I was stunned when I saw it. So this would be the normal innervation of the outside of bone. Where you see the little green cells here, those are the sarcoma cells, which basically are growing in this area of bone. And suddenly you see the sprouting which is occurring here, which almost looks like a neuroma. This is what's happening in your cancer patients. They're getting this ectopic sprouting. There's probably an ectopic group of receptors and channel here, which then can cause spontaneous discharges. And if you basically take a normal bone, this would be the normal femur, and you just overlaid it with the sensory fibers which are normally there. Here we have the same bone except sarcoma cells, green cells are now growing on top, basically in it. You can see how pitted the bone becomes. Remember how this has a smooth surface? Here, you can actually see that it's digesting the bone, and you get all of this aberrant sprouting, and you also begin to see these little neuromas forming. So this was truly impressive. We just didn't expect this, and I think that this is happening not only in sarcoma, it's happening in breast cancer, it's happening in, you'll see in a moment, prostate cancer. I think this is a regular thing which occurs when tumors invade the tissue. One of the questions, though, became, it turned out that the cells that we're using here are sarcoma cells. If you look back in Rita's original data, when she was originally putting cells on top of the sensory neurons to see them grow, sarcoma cells was the thing she first used before she knew nerve growth factor was there. So sarcoma cells express small amount of nerve growth factor, but prostate cells don't. You can see where this is leading. If basically all of the nerve growth factor is coming from the cancer cell, every time you're going to treat a patient, you have to biopsy the tumor to see, is the tumor expressing nerve growth factor? If it is, then you would treat it. If it's not, you wouldn't. So we had a prostate line, though, that made no nerve growth factor, and the question is it going to be the tumor, or is it going to be its associated inflammatory immune cells, which are making the NGF? And the bottom line is, this is what it looks like when you inject a prostate cell in the bone. Notice how different it is from the sarcoma. They have these little cancer cell colonies here. You can see the green prostate cells here, and they form along the bone, here, here, here. And the only point I'm trying to make here is that in a tumor, the majority of the tumor is actually inflammatory immune cells. It's not the cancer cells themselves. So this is just a GAPI stain, which stains all the nuclei of the tumor, and this is just the tumor cell itself. The bottom line is that there's a whole lot more inflammatory immune cells in a tumor than there are actual cancer cells. Do tumor cells, so the prostate cells, make no NGF? Do you actually still get the sprouting? The answer is yes, you do. So this would be the marrow space. You'd see one little nerve fiber here, one little nerve fiber there. This would be in the mouse bone. This is basically what you see early on. This is what you see late. I mean, again, it's just this amazing nerve sprouting which is going on, which you and I never would see in our bones, that these patients now have. If you say just how many more nerve fibers are, I mean, in this particular animal, there were 72 times as many nerve fibers as you normally would have. The bottom line is, the more nerve fibers you have in an area that aren't supposed to be there, that's not a good thing, especially when you have cells spilling out other things like prostaglandins, NGF, etc. And then the question obviously is, well, can you block it? And the answer is, this is what you would see when you have CGRP fibers or NF200. This would be in the normal marrow. This is basically the prostate cells plus vehicle. And then if you give the anti-NGF, you could basically largely block the sprouting. So not only do we actually have a mechanism which is driving neuropathic pain, we have a therapy which we think can largely block the sprouting and stop the neuropathic pain from developing. And again, in these particular animals, you get about a 50% reduction. It's not as if we're relieving the pain, but we're attenuating it by 50%. So at the end of the day, I think what it has taught us, the studies have taught us, is there's three major mechanisms which are driving bone cancer pain, and probably a variety of other cancer pains. And I think in each one of them, we've then been able to identify a variety of things, some of which have been approved for treating bone cancer, some which are in human clinical trials. But for the first time, I think we actually are beginning to get a scientific idea of what is driving the pain, what can we actually treat the various pains of the patient with, and how can we relieve their pain, basically improve their functional status, and potentially also increase their survival. And lastly, none of this could really have been done without the clinicians. In all cases, we really worked hand in hand with the clinicians to make sure the models that we were using were basically correct and reflected what they saw in the clinic. Obviously, the basic scientists, the work with pharma, government agency, but really the people did all the work in the lab were the young scientists, and these are these are the individual, these would be the clinicians and the collaborators. This is the guy who mostly watched and didn't do anything, but these are the ones who got the work done. And similarly, this was the imaging group down in Arizona that was able to show the sprouting for the first time. So I think my major message is, if clinicians and basic scientists work together, it's amazing how much you can accomplish. And if you have a good young team basically to help you with the work, you can accomplish a lot. Thanks very much.